Hi, good night. Today we have to continue with our theoretical plan. And well, it's 8 and 2. And Laura just arrived, the first one. Good night, Laura. How are you?
Good night, teacher.
Well, my dear, we are alone together until this point, so let's wait for our classmates, okay?
Okay, teacher.
Okay, there's no holiday for tomorrow, so we have normal activities, okay? So I'm gonna give the same information to your classmates, but it's strange. They are not getting into yet. Just you, yeah. That's great. We can work together
Okay,
properly. Yes, let's wait a little bit.
Okay, teacher.
Okay, in that way, I'll be back in 5 minutes, okay? In 5 minutes, if you are alone until this point, well, we are going to work together, okay?
Okay, teacher.
Okay, see you in 5 minutes.
Okay, teacher. See you.
Okay, good night, Alejandra, Diana, Laura. Let's start. I think it's enough time waiting for your classmates and patients. I think they are gonna get into while we are going ahead with the class. Let's do it because tonight we have lots of new concepts and new ideas to check. And of course, we don't have enough time to spend reading for people. So patience, let's go ahead, okay? Tonight we are going to check very fast the screening and immunization, general concepts about epidemiology, and medical ethics, the basis of our job when we consider the moral part of our activities, okay? Let's start with screening and immunization. And we consider all of this information. In this chart, in this slide, we are checking again words that are in black. I mean, blackened words showing us a specific vocabulary again. Please practice with this. It's going to be into the homework pile. And well, there are ideas that we usually talk about during Spanish. And in English, of course, have the same meaning, but maybe the way of expression could be a little different, maybe. It's according to the situation, we can focus on that. Screening is a way of identifying people at increased or greater risk for a condition, although they don't yet have any signs or symptoms. In some cases, mass screening a large number of people is appropriate, for example, in the past for tuberculosis. In other cases, only those with high risk factors, like family history of conditions such as cancer and diabetes, are screened. However, there are a number of problems with screening. There are always false negatives, cases where a patient has a disease, but the screening doesn't identify it. And there are also false positives, where someone is told they have a disease when in fact they don't. Furthermore, with some diseases, early identification is of benefit of the patient as there is no treatment available, right? We all got these ideas during the med school, during our own experience, and we can realize that risk factors are always present. Family history is a basis evaluating a patient, and false negatives shouldn't occur, but when they happen, well, we have to solve the solution, of course. Same with false positives, right? This is a chart when I'm showing you some screening tests, the common ones. There was common, I'm gonna fix this, okay? Common screening tests during our job. I mean, we got, for example, the condition, the neural tube defects, and Down syndrome risk. Following these situations, we evaluate the AFP alpha-fetoprotein, right? Of course, in pregnant women, between 16 and 17 weeks. We all know how it works. Okay. Following these ideas, we got same way to organize this information, checking the breast cancer. It is usually to ask for a mammography in women from 50 to 70 years as a range. And the frequency every 3 years, according to the situation, right? About the cervical cancer, we prepare the smear test. Women 20 to 60 years old, every 3 years, if there is no higher risks, could be said. And 20 to 6, according to the situation. If the patient started her sexual intercourse earlier, of course, the smear test starts earlier. Cardiovascular disease, we usually use blood cholesterol. Subjects up 40 with high risk of factors. I mean, blood pressure. I mean, well, if the patient is obese or something like that, right? Every year. When we talk about secondary condition, it's when we got the a pathological situation, for example, hypercholesterolemia, when the value is up to 4. In the secondary prevention, we only look for complications, right? Again, we follow the blood cholesterol, and we usually look for patients with heart disease. They are our subjects every 6 months according to the situation, the range, the frequency. When we talk about diabetes, we consider diabetic retinopathy as one of the most common situations of blindness in people, in diabetic population. We develop the ophthalmoscopy, of course, in patients with diabetes every year. But if something is different, we can change it. And well, we use the frequency we certainly need in each case. Okay. This list, some common screen tests are showing you more ways to evaluate patients. For example, the PSA tests for prostate cancer, the ocular pressure for glaucoma, the TSH for hypo or hyperthyroidism, right? So check this slide, it's interesting, I think. Okay, in these screenings, we all know we got the objective to prevent, to make prevention, prevent complications, prevent the onset of a situation. Or if we find during pregnancy genetical disorders, we can talk to parents, or the doctor, the genetist has the chance to talk with parents, and they decide if continue with the pregnancy or not, according to the situation they are living at the moment, right? About immunization for travelers. Well, we know everyone who has traveled to another country has to bring with your passport some immunization carnets, immunization IDs, showing that you have specific immunizations, because Bolivia, we are endemic in some situations like yellow fever, for example, like malaria. In that way, travel vaccines are specific immunizations given to travelers prior to going to certain areas to protect them for acquiring serious life-threatening diseases. Examples that I was telling you, Chagas could be, but there's no vaccine. Yellow fever, malaria could be great examples. Or nowadays, well, in the way it was expected during the pandemic times, the COVID-19 vaccines, okay? Why does a fully vaccinated traveler mean? Of course, a fully vaccinated doesn't mean that has to get all of the vaccines from all of these diseases. That's crazy, right? The fully vaccinated means that if you had received both doses of an accepted 2-dose vaccine series, regardless of how long it has been between doses, you are considered fully vaccinated. I mean, usually some pathologies require 2 doses. If you receive that 2 doses, great, you are fully vaccinated. If you need just 1 dose, you show that you have the ID with that 1 dose, with the label of the vaccine, that's great. You are fully vaccinated, you can travel. In this chart, it's previous to COVID-19 vaccine. We got lots of situations, lots of diseases and illness that are preventative. In this way, if we want to go, for example, from Bolivia to North America, in that period of time, we must go with anti-influenza virus vaccine as a new one that it's not into the ID vaccine when we are babies. This anti-influenza is according to the period of time you are going to USA. Of course, not to the whole year you are receiving the same. It's according to your pathological to epidemical chart at the moment you decide to travel. Nowadays, it's still asked for in USA the COVID-19 vaccine and the yellow fever vaccine and malaria vaccine. Following all of that information, you can receive well, you are one step into that country. Well, coming to South America and Central America, you got all of these situations for moving between countries. Anti-influenza, anti-yellow fever, malaria, rabies. Rabies is so important. Hepatitis, IMV, typhus vaccine. Well, checking this. Similar situation to Africa, Middle East, Europe, well, every continent. So it's your choice. If you travel, you have to take them. And according to the country you're getting into, well, they ask for specific vaccines, okay? Well, this chart is just for showing you more vocabulary and expressions like this, person-to-person contact, for example. That's the way how vaccination is recommended for travelers to South Asia. For example, rabies. If you might have extensive unprotected outdoor exposure in rural areas, you must go with rabies vaccine. Okay. For example, as needed is in, well, lots of countries are asking for anti-tetanus vaccine. So if you go to a country that you're going to be in outdoors activities, exposition without protection, I mean, going to lands, going to some graves, well, something like that, you certainly need it because for preventional activities, right? Don't worry about it. Same with diphtheria, measles, and one-time dose of polio for adults. I mean, that's according to the situation and the place you are going on. Usually in embassies, they give you a list of vaccines you certainly need to get into that country, the country you're looking for. About epidemiology, well, there's the big cake in this presentation. We are going to check lots of information, lots of new vocabulary. That's why it's important to consider or to remind how it certainly works, okay? Epidemiology is the study of distribution and determinants of health-related states or events in specified populations, and the application of this study to the control of health problems. We know epidemiology is one of the bases in our research activities because all the data that we collect is translated into numbers, and that numbers into an objective information that we can share and compare with colleagues according to situations we are looking for. And then following that numbers, we have the chance to propose changes and control the changes, okay? This chart shows us how epidemiology works. We have public and healthcare providers, clinicians, laboratories, hospitals, well, all places where patients are receiving attention, are with assistance, medical assistance. They prepare reports, clinical histories, prepare information, and they report all of this to the health department. Health department evaluates the information and checks how the values are going on, if they are going high or low. Well, they evaluate all of this and make a feedback, giving us recommendations for improving or changing the way we are working on. And then from that recommendations, we develop the changes, we make all the activities they are asking for, and again, we send the report and they make again the evaluation, and then the feedback, and that's a cycle. That's the way it works. In that way, that's epidemiological job. We have to consider this for catching or for organizing the information properly. One of the bases of this reporting for making values in a chart, and that chart is going to be useful, is, well, they are used in rates. We all know about it because during the med school we have the chance to talk about rates so frequently. I mean, the speed or frequency with which an event or circumstance occurs per unit of time, population, or other standard of comparison, right? For example, as you can see, we got our blue guy. I mean, this chart is important. We talk about frequency using words with rate. Could be birth rate, the number of births in a population, a group of people. We are making in a number how many babies are coming on, right? Death, I mean the mortality, the death rate, the number of deaths in population. We study how many people is dying, how many people is in birth. In that way, we can compare values in a period of time, and we can show how our population is increasing or decreasing in values, in numbers, okay? Case fatality rate, the number of deaths from a particular disease, for example, hypertension, cancer, I know, tuberculosis, well, things like that. Survival rate, the number of patients still alive after treatment for a particular disease. For example, cancer, for example, COVID-19, right? That's an example. Checking this bubble. The birth rate in Singapore is 10.2 per 1,000 population. Or another way, the infant mortality rate in Singapore is 3 per 1,000 live births. Just examples, how it works, how we can say. Other words that we can use when we talk about frequency are common, uncommon, and rare. They are, in my opinion, they are better to use because we show that we are making an interpretation of a number. Numbers usually can sound boring, not so clear, not making a properly explanation. Or percentage is the same. It's not the best way to talk with numbers, with values. It's better to use expressions like this. For example, malaria is common in many developing countries. For example, Bolivia. Or malaria is uncommon in developed countries. For example, UK. Or malaria is rare in developed countries. Okay? Uncommon or rare are considered synonyms into this context. That's why the term you choose to tell or to use during the explanation, that's correct. Don't worry. Moving ahead. Well, here I'm showing you some examples how it works. For example, the pie chart. We know that it's in colors, like a pie with every color is a percentage. We have more rates, the line rates, when we consider and following the trace, how these changes are coming on. Talking about incidence and prevalence, we get the definitions. Prevalence is the number of people in a population who have the disease at a particular time. Just for a small period of time, prevalence. Incidence, the number of new cases of the disease during a particular time. Incidence, new cases. Prevalence, number of patients, we can say. That's the formulas, just an example, okay? And now expressions, how we can talk about them, how we can give this information to our boss, we can say. The incidence of malaria is high in many developing countries because we have too much patients with malaria. That's why it's high, it's going up. The incidence of malaria is low in developed countries. There are not many patients. Maybe there are uncommon cases, usually imported cases, but patients get the disease in another country, comes back home, and then shows the infection, okay? There are non-common situations. Example, the incidence of HIV infection is highest in sub-Saharan Africa. Could be. We know that the HIV in Africa is a huge trouble. Or another way, the incidence of HIV infection is lowest in the Caribbean. Well, could be lowest if we make the comparison with Africa, okay? Note, you don't say the incidence of malaria is common. Of course not, because we use Haigor law in order to make a comparison. The incidences of a disease in a different groups are often compared, right? Haigor law for making a comparison like this. Highest in sub-Saharan Africa, and we can complete. Then in, I don't know, then in Granada could be, okay? Another way to say this, another way to express, using more common, less common, or equally affected. Could be rheumatoid arthritis is more common in females than in males. Correct. Rheumatoid arthritis is less common in males than in females. It's general English, yes, we all know about it. But let's check this. More common, more patients with this situation. Less common, less patients with this situation. And men and women are equally affected by restless leg syndrome. I mean, the comparison in that two groups have the same way to be affected, are equally affected. Ahora sí. Association and causation. When we talk about association and causation, we consider that how a cause is giving us a consequence. It's a chain of events, and that chain of events has the opportunity, we can say, to understand how diseases work. That's why studying the incidence of a disease in a particular groups of people can lead to the discovery of a causation. What makes it occur? If we find the origin of a disease, we follow all the events that are coming and we can study the consequences. For example, the high incidence of lung cancer among cigarette smokers suggests that smoking is a causative factor in the development of lung cancer. Okay, we use suggest at this moment because for ensuring this, we need lots of years of studies. Of course, in this example, we got the answer. We know that smoking is a cause of lung cancer. But for practical reasons, that's a good example to understand how this part works, okay? We got this chart when we have the risk factor, the component causes, the biological effect, and the health outcome. I mean, how it starts, how the disease is coming on, is going on, and the consequence. However, care must be taken, not assume very association between a disease and a measured variability is a causative. To say there is an association between two things simply means that they occur together in certain situations. I mean, you got specific situations And you don't have to say that there is just one origin of a pathology. You get lots of explanations, but in the case of our patients, of every patient, we try to look for the origin of this specific situation from this specific patient, okay? I mean, several studies have indicated high rates of lung cancer in cooks. Why cooks? Because they are breathing, they are receiving all the fumes, all the smoke, so we can say all the things into the kitchen, and they have the chance to develop lung cancer. Instead, they are not smokers, right? This could be a consequence of their work. This is a risk factor in job, right? It may be simple because professional cooks smoke more than the average. In other words, smoking, no matter if it is the vape, if it's a cigarette, if it's the cook, smoking in general, as a big word, might confound the association with cooking, okay? We know that nowadays the new rule for smokers is not using the cigarette, it's using the electronic cigarette. The electronic device leaves that fume that with different tastes. I mean, could be fruits, could be veggies, could be meat, could be just a perfume. Well, we know that fume that is free, that is inhalated while smoking, that making the action of smoking, is now a cause of lung cancer in young people, in teenagers with serious lung troubles, lung diseases, because with all the components it uses in order, it's an electrical device. That's why we consider this as a new cause of lung problems in younger patients. The risk factor could be losses. I mean, patients with from developing countries or without the same opportunities. I mean, poor people. Losses, a social determinant, of course, is a basis. The component causes: tobacco, smoke, and pollution. Nowadays, here in La Paz, well, in Bolivia in general, we are having trouble, a huge trouble about pollution because of the chaqueos, right? Lots of fires around the country in the Amazonas. In fact, we received the order to close schools for some days in order to control or to prevent some consequences in kids. That's why pollution is a very big fact in this trouble. What causes? The component causes go ahead with a biological effect, mutations in respiratory cells, and the health outcome in a period of time, of course, the lung cancer or lung diseases in general. Could be COPD and a consequence, could be chronic bronchitis again, okay? Lots of consequences that we must consider at this moment. This is just an example, but of course we can practice on this a lot. We have a lot to talk about this specific chart, considering different situations, right? Medical ethics. I mean, we all had the chance to talk about it during the med school because we got the chance for practicing, for checking this information and noticing that it's a basis of our job. We as doctors have the chance to become a ruler into the society. I mean, we got that role that if doctor says something, everybody says, oh, we have to respect that opinion because doctors certainly know what they say. We have to consider that opinion because doctors study for helping people, so they got a very different point of view, and we can consider that they are not cheating us. They are not lying us. And in that way, we have to respond to that society confidence. Being so ethic, being correct in the way we work on, in the way we try to explain or to show something in order to make our best and looking for the best of our patients or population in general. Medical ethics is concerned with the obligation of the doctors and the hospital to the patient along with other health professionals and society. The health professions has a set of ethics applicable to different groups of health professionals and healthcare institutions, of course. They are their concerns, I mean, that are done through the history. We doctors, we can rule society without any trouble. We have the chance to give an opinion and be respected of this, right? That's why we support in these 4 pillars that are important for us. The pillar of beneficence, the pillar of non-maleficence, the pillar of autonomy, and the pillar of justice, right? When we say the pillar of beneficence, is when we look for the good, to become good, to become better for others, for patients, for every people. In medicine means acting in a way that helps your patient, always looking for the best solution to our patient by individual. We cannot work in groups, right? We only work, we work individual because we got, for example, an anatomy. We memorize a general view of the body, we memorize anatomical landmarks, specific details, but we know that all patients can have exceptions and not have a specific detail, maybe have another different. For example, that small bones in hands and foot, that were menos and sesamoideos, certainly, I'm not sure how to tell them in English, but that small bones that are uncommon, maybe I got some of them and you don't get them. That's why we try to work by individual. The most obvious example of this, providing up-to-date, evidence-based treatments to your patients with aim of reducing their symptoms or treating their illness. When we talk about beneficence, we have to be clear on this. We need a proof to be clear. Okay, so let's consider this. When we fail on the pillar of beneficence, we are talking about negligence. Negligence is when I work without that part of my ethical acting. We can get into these experiments, we can say. The Tuskegee syphilis trial is one of the most, is one of the biggest trials when we can notice that beneficence was avoided because, Tuskegee was a town, a very small place in USA, when syphilis was a really big trouble, a huge problem at the moment. And a group of doctors, that was a Black community, and a group of doctors get into that Black community and said that they had treatment for patients, and that was by free. Of course, they become so happy because they were poor people, and they decided, the people of Tuskegee decided to accept the treatment. But there was the deal. They will receive the shot and would be under control of the doctors for a period of time. I mean, 1 year, if my memory is not failing. So in that way, the Tuskegee population, the Black community, were analphabet. They couldn't read the contracts they were signing. And they were getting into a trial. They divided into groups A and B. The group A might receive the medication, might get the cure, and the group B might receive a placebo, just water in the shot. And doctors, without giving them the explanation that they were into trial, were comparing how syphilis was getting recovered and how syphilis was getting into some complications. And we know because of this trial, all the stages in syphilis disease, right? That's why it's ethical acting But from that wrong acting, we got new science benefits. Same or similar situations could happen with lots of experiments, of trials in psychology, in psychology, and psychiatrists. So let's consider this. This chart is showing us the extremely small resume about this situation, okay? Read this, it's very important. It's interesting, and knowing the history of medicine is great. When we talk about the pillar of non-maleficence, means not causing harm to your patients, okay? The principle spans a range of applications, such as doctors maintaining medical competence and not giving patient treatments where the risk outweighing their benefits. I mean, if you don't know how to develop a procedure, don't do that. If you don't know how to insert a device, a scope, don't do that, because you are not viable for doing it, okay? So considering this is important, because it's a basis, the non-maleficence pillar, because we have to be well prepared of doing this. If we are not up to date, we use old treatments, we are making a very wrong, a huge mistake, because things are changing. If we don't consider risk outweighing the benefits, the treatment is not correct. It seems obvious, but, well, sometimes it happens, okay? For example, Harold Shepman was an infamous GP in England, okay? Because he was killing patients while sending high doses of opiates. I mean, he decided to kill them because it was not important for him. It was just spending time for the government. And he said, okay, goodbye, people. That's a maleficence activity. Then the pillar of non-maleficence was broken, of course. Goodbye, medical activities, right? And of course, getting into jail. The pillar of justice shows us that doctors, we have the obligation to work on justice. It refers to fairness within medicine and equal distribution of resources. It's just a dream, in my opinion, because any country has that capability to make that distribution. It can be considered in terms of equality and equity for healthcare across patients. For understanding, we got this: equality, equity, and justice. Equality, giving everybody the same situation, the same benefits, the same medication, everything the same. And as you can see, some can receive something that is working on, that's great, but a part of people is still having trouble. When we talk about equity, I mean, we give the resources to our population in order their needings. I mean, for all of them checking or having the same situation, one of these guys is not receiving anything, maybe something, and lots of resources. It's not correct, but it's about according to the situation. They have the same benefit, but with different resources. When we talk about justice, we try to prepare all the situations when everybody receives the same resources and gets the same benefits. As you can see, instead of a closed BART, we got this new one, okay? So justice is looking for this part, but it's according to the situation. You try to work and find this, the justice situation. Not always is possible, of course, but we try to make it better. When we talk about pillar of autonomy, in my opinion, is the worst Because, well, it's the self-determination of the patient. I mean, patients have the right to make their own healthcare decisions, okay? If they make their own decisions, it means that we as healthcare providers, as doctors, we give an advice and the patient decide if it takes or not the recommendation or the advice. Patients can decide their own healthcare priorities, and it includes the right to refuse treatment. That's the worst part, they refuse treatment. We should inform and advise patients according to the medical evidence, but the final decision should always lie with the patient, even if it goes against medical advice. We all know about it. If the patient says no, it's no. When we talk about self-determinance, the autonomy in patients, we consider as the most common example the Jehovah's Witness. They always refuse a blood transfusion, always, because they consider that soul is into blood. They say that if you receive a blood transfusion, you are receiving the soul of someone else, and who knows who's that guy. That's why it's not possible in their religion. That's why that religion grounds make mistakes, makes patients take bad decisions. This may seem medically unwise because we know why we are asking for a transfusion, but they say no. So patients, we can do anything with it if they don't accept it. In that way, patient has the right to refuse this treatment. Okay, that's why we get into many ethical challenges, including the areas of consent and capacity. When we talk about consent of capacity, we have to consider the situation of the patient. If the patient is unconscious when getting to the medical service and we didn't have any idea about Jehovah's Witness and that religion, or if the patient is not into the loyal age, I mean, if it's a kid, for example, and, well, it's against his life, the religion of parents, we can look for resources, loyal resources, for changing or taking away the opinion of parents and saving the kid's life could be. Or maybe if there's an accident and we decide to save life instead of these beliefs, could be situations for taking in account, okay? It's a huge deal to talk about it. The General Medical Council guidelines, it's a paper, it's a lots of steps in UK that give doctors an idea how their job should be. I mean, make the care of your patient your first concern. Treat every patient politely and considerately. Give patients information in a way they can understand. Keep your professional knowledge and skills up to date. Recognize the limits of your professional competence. Of course, if you are not a surgeon, don't get into operate. No matter the situation, don't get into professional troubles, okay? Be honest and trustworthy. Respect and protect confidential information. Of course, every anamnesis is confidential. We all know about it. Make sure that your personal beliefs don't prejudice your patient's care. Act quickly to protect patients from risk. If you have good reason to believe that you or your colleague may not be fit to practice. If you are watching that your colleague is doing something wrong, politely go and exchange, help him or her to do it better, or develop the procedure by yourself, teaching your colleague. It's not a mistake. It's just making the best for your patient. Tell you by experience. If you don't know how to develop, for example, the correct maneuvers of CPR, don't develop them. Don't break ribs, please don't break ribs. It's important to save lives, not to make more in trouble, okay? All of this vocabulary, of course, it's important. Check this. And while black and words, always our specific vocabulary. Okay. About bioethical issues, Well, we got the euthanasia, human fertility, transplant surgery, genetic engineering, just as an example. Euthanasia, we all know what it means. When we decide to die, well, we get assisted dying, okay? The assisted dying in some countries is loyal now, but in our countries, I think at this point, it's not loyal, it's not possible to make. So what should I do? Try to save a patient's life because it's my activity, no matter if he's suffering pain all the time, or just administrate some medication to avoid the pain and of course finishing life. It's so hard to decide this. That's why it's a bioethical issue. It's a bioethical trouble. About human fertility, how many rights we get in our life to decide or to play like being God and, I don't know, bring new life without preparation, without just going to science. I mean, embryos can be frozen and implanted in the mother later date. Okay, but why we do that? If it's not the time, it's not the time, and that's all. We cannot choose how to make it. Okay, it's very different. Or in vitro fertilization, how it works. We should try to force a pregnancy if certainly that body is not prepared for that. Or what about the rights of surrogate mother? They are just ovens. What they are? Or they are just looking for lives of a kid. About the transplant surgery, who could give the consent of the removal of the body parts of transplant surgery? I mean, could be the patient, relatives, could doctors choose for them? Could we make it as a priority in our activities in order to help to correct the situations for patients who really need a transplant? We can look for alive donors, or maybe just dead donors. So high, so difficult, right? What about genetic engineering? What about embryos to be cloned? Is that correct? How, in which moment we decide to play as God and decide when to make the same copy from you and take care of them in maybe a different way to look for if it's going to be taken different decisions? That was an experiment that was a proposal of experiment of a trial when we were talking about the cloning activities in humans for comparing how people could act. We can clone 2 babies, we can get them growing up in different social situations, different social status, and then look for if they make similar decisions, different decisions. It's like, do you remember that movie? I almost forgot it. The Truman Show with that amazing guy. I forgot his name now. Jim Carrey, with Jim Carrey, the Truman Show, when all of his life was under a lens and everybody could watch how was his life going on. That was a trial because everything was a lie. But what would happen if you compare a clone of 2 babies and then look for them like the Truman Show and decide? That was a proposal in psychology, and of course it was denied, but it's a good trouble. What should I do? What should I believe on? About assisted dying, we got this vocabulary. Please read this chart, practice on this chart. When we got incurable muscular dystrophy in Switzerland, well, the assisted dying is legal in Switzerland, but illegal in UK, USA, many countries, okay? So what should I do? The participate to be struck off, or it's better to continue in palliative care, okay? So please read this chart, check the specific vocabulary, and we are going to talk about it tomorrow during the workshop, okay? And don't worry, keep educating yourself all the time. That's the key of going ahead. Let's close this. I'm gonna send the pool to take attendance. And in that way, I'm gonna send to the chat the presentation. So give me a moment, okay, to send you the slides. Hey, my kids are crying now. I have patience. Okay. Please let me know as soon as you download the file, and then you can leave, okay? Thanks for your attendance. Thanks for coming tonight. I really appreciate that because, well, tonight I know we are in a party, but, well, a religious party, but, well, our obligations first. That's the way I think. So, any question you got, you can send me a message by WhatsApp. You know about it. Okay. Thank you. I'll be back.
Dr. Iris.
Okay, Jimena, could you download everything? I mean the presentation, and could you fill the pool?
Doctor, can you send me inbox, please?
Okay, no worry. Please give me some minutes to do that, okay?
Thank you very much, doctor.
Okay, did you fill the pool, Jimena?
Yeah.
Okay, perfect. So I'm gonna send it to you in a couple of hours, please. I need to take care of my babies. And, well, I'm gonna send you the presentation. Don't worry about it.
Thank you very much.
Okay, see you tomorrow. See you during the workshop, okay?
See you tomorrow.
Okay, bye-bye.
Bye, doctor.
Okay, everything is done. Everything is already finished. So see you tomorrow during the workshop. Have a great night.